So my name is Hammad Ashraf. I'm a DO internal medicine attending now. I just finished residency back in July. I went to AT Still University and I did my residency in a pretty urban or rural, I guess, place in Cottonwood, Arizona, which is basically the middle of nowhere, but a lot of old people go there to retire. So you see a lot of complicated things.
And what was your path leading up to your position now, starting from undergrad?
So I always kind of knew I wanted to do medicine, or I guess I was told I was going to do medicine by my dad. Um, but no, I kind of always wanted to do medicine. I wasn't forced into it. It was most like I was kind of like, I'll work is always just going to be work for me. So I was like, why not do something that gives you a stable job, a good income, and you can help people. So I knew I always wanted to do medicine from like high school. Going into undergrad, I kind of wanted to, I don't want to say game the system in a way, but like get an edge over everybody else applying for medicine and not do something science related. So initially I went into computer science. I did 2 years of computer science. I didn't really like it, mainly because ASU's computer science program is not the greatest. So then I switched over to political science, still a non-science major, and did that for my undergrad and then applied for medical school. And the reason for that is, and I don't know if this has changed since I applied for med school, but a lot of medical schools keep a percentage of their seats for non-traditional graduates, which means like non-science majors, like not biology, not chemistry, not physics, like non-traditional science majors. So that's why I went political science route. I graduated in, so I was initially going to graduate in 3 years, but I didn't get into med school the first go around. So I did an extra semester and got a minor in religious studies, and then applied again and got in the second round.
And would you say to those people applying, is being a non-traditional major actually maybe a disadvantage to how people see it, or would it put you at an advantage now because there's so many people doing that biology or chemistry or biochem major?
So there's a few, in my opinion, there's a few advantages to doing a non-traditional major. One is generally your classes are going to be significantly easier than the science classes. Like, yes, you have your med school prerequisites that you have to take no matter what your major is. Those are pretty basic and easy classes, but the higher level classes you have in biology majors, chemistry majors, physics majors, those are really hard classes, and it's generally pretty hard to maintain like a 4.0 GPA with that. And a lot of the non-traditional majors, they're fairly easy classes, and you can kind of focus most of your attention on like the med school prereqs and doing good on that and doing good on the MCAT and get A's in the rest of the easy classes and maintain a good GPA. I personally think it's an advantage because most people are still doing the traditional, like, oh, I'm doing psych, or I'm doing biochem, or I'm doing biology, and then going to medical school. Also, med schools love to see someone who's more well-rounded than someone who's not.
Yeah, and at the same time, how did you manage to fit in like time for your extracurriculars and also time to study for the MCAT?
So, I mean, like I said, doing political science really helped me because, like I said, you don't have that. Like, if you choose an easy major, like let's say political science, or you choose something else easy, like maybe, well, it depends on who you are, but for some people, math is easy, right? For some people, computer science is easy. Whatever is easy for you, then you don't have to spend that much time doing those things, and you can spend more time doing your extracurriculars. So for me, political science was a very, very easy major. I would like finish it would maybe take me like 3 to 5 hours a week to do everything I needed to do for those classes, because most of them you didn't even have to attend, everything was online. And then I'd spend the rest of the week focusing on like the stuff that matters, like shadowing and the research, although I didn't do that much research, more so like case reports and like studying for the MCAT.
And when applying to medical school, how many schools did you choose to apply to, and how did that affect your acceptances?
So for me, I wasn't willing to go anywhere. I wanted to go somewhere with family. So I applied very region based. Like I applied in Arizona, I applied Texas, like Michigan, Buffalo. I didn't apply everywhere in the United States. One, because that's a lot of money. Each school you apply to is I think like $80 or $100. And then I didn't want to go far from family, and mainly I wanted to stay in Arizona. So I interviewed at both the DO and MD schools. I got accepted into MD schools out of state, but nothing in state. The only DOs I got in state, so that's why I ended up going the DO route.
And I know that COVID played an interesting role in your time in med school. Can you tell us a little bit
Yeah,
about
so
that?
COVID was actually towards the tail end of my third year and the beginning of my fourth year. Um, I actually got lucky because of COVID, they stopped doing a lot of they stopped taking a lot of students inpatient rotations. So I never wanted to do surgery. I had absolutely no interest in surgery. So I got to skip doing my surgery rotation, and it was an online rotation where basically it was just like busy work and watching videos, because they weren't taking students because of COVID. Um, I think my class was probably the most impacted by COVID because we were right there doing clinical rotations. Like the first and second years, it doesn't matter because you're going to school anyways. But the people doing clinical rotations, it was like we were at rotations, and then all of a sudden they're like, okay, don't go to rotations anymore. Everything's going to be remote. Um, I do think it did affect what we saw because the inpatient rotations that we did do, almost it was like 99% people have COVID. But it also did make med school a lot easier. I think it made residency easier, not only for that time, but also going forward because I know most med school, or I don't know about med schools, but I think a lot of med schools and almost all residencies since then have switched to remote interviewing, which they weren't doing before. Like you would have to travel for every single interview you wanted to do. So that was a benefit, and I think COVID helped more than it hurt, especially the telemedicine part of medicine. Because I think we would have gotten to where we are with telemedicine now, but it just would have taken longer if COVID hadn't happened.
Mm-hmm. And from your 4 years at medical school, would you categorize maybe one of them harder than the others?
I think, ooh, that's a tough one. So my medical school is a little bit different. AT still, they don't do this anymore, but what they used to do is you only did first year on campus, and then second, third, and fourth year you go to community health centers all over the country. So there'd be 10 group of 10 students would be located centered at a community health center. So there were 10 students that went to New York, 10 students that went here, there. So mine was a little bit different because we only spent first year in the classroom. But I do think the hardest year probably is third year, mainly because you have to take your step 2 or level 2. You have to do well on your rotations. The third year is the most important for residency, right? Because first year, second year, you study your books, you pass your tests, not that big of a deal. You take level 1 or step 1, which is kind of difficult, but in third years where you have to get those letter of recommendations, it's where you have to start thinking about what you want. That's basically the year where you build your resume for what you want to do. So I think third year is probably the hardest because that's also when you're doing your rotations. You know, you're no longer just like watching videos or studying practice questions. You're actually there. You're seeing patients. You're expected to do the long hours that residents do. So probably third year.
Mm-hmm. Is there any advice specific to receiving letters of recommendation now, entering and being in that third year?
Yeah. So do the best you can possibly do, and like put in extra effort if you want a letter of rec. And let your preceptor know early. Like let them know in the first week, hey, I'm interested in getting a letter of recommendation. Could you keep that in mind throughout the rest of this rotation? And then when you approach them again, maybe in the third week, because usually rotations are 4 weeks long, in the third week, be like, hey, do you think you'd be able to write me a strong letter of recommendation? Because most preceptors will write you a letter of recommendation, but not everybody will be willing to write you a strong one. And if it's not a strong one, you don't want it. Because you can't read your letters of rec. So tell them only if they can write you a strong one based on your performance should they write you a letter of recommendation. But just doing your best and making it known that you want one and that you're interested in that subject. And honestly, this shouldn't be the case, but a lot of preceptors give more attention to students who are interested in their field. And you shouldn't have to do this, but a lot of times you're gonna have to, even if you're not particularly interested in the field you're rotating in, tell the preceptor that you are, so you don't get like ignored. That's kind of it is what it is. It shouldn't be that way, and not all preceptors are like that, but quite a bit of them are.
And what is it like applying to the different residency programs?
In terms of like,
what do you have to get prepared and ready?
So-
interviewing skills.
yeah, so interviewing skills. Honestly, once you get an interview, at that point, it's mostly how your interview goes. It's the getting the interview that is like getting your foot in the door. For medicine, unfortunately, and it's probably going to stay like this forever. It shouldn't be, but nepotism plays probably the biggest role in one getting into med school, getting into residency. If you know someone who knows someone, or you know someone, that will probably get you your foot in the door, and then from there on, it's proving yourself. So basically, how it works, all residencies have filters. So they'll say, hey, we don't want any candidates that didn't pass step one the first time, or don't have, well, now step one is pass fail, but before it was like, don't meet this certain criteria, like someone who doesn't have like, isn't top 10% of their class, or someone who didn't already take step three, or someone who didn't have this minimum score on step two. They have filters, so they'll just filter out all of those people, and they will only give interviews to people who meet those certain criteria, and you don't know what those criteria are for different residencies. So once you do get an interview, that means you meet their basic criteria, so they are at least interested in you at that point, in my opinion, from what because I did do some interviews when I was a third year in residency. Once you get to the interview process, at least in my program, your stats at that point don't really matter anymore. It doesn't matter what you got, it's how personable you are and how teachable you are. And honestly, people really want someone who's easy to work with and easy to teach. As long as you meet their minimum requirements. And sometimes even if you don't meet their minimum requirements, some program directors will prefer to, and residents will prefer to work with someone who's like easy to work with and easy to teach. They don't care that you're like got the best step one score ever, like, right? That really only matters if you want to go to like Harvard or like Ivy League schools for residency. But if you're just wanting to get into residency, get into a good program, it's your personality that matters far more than anything else.
Why internal medicine?
So actually, funnily enough for me, I actually wanted to do psych. But psych was very, very competitive my year. So I dual applied psych and internal medicine. Psychiatry has gotten way more competitive since then. It's basically everyone wants to do psych because lifestyle is amazing. Basically no call. Liability is very low for psych, and you get paid fairly well. But I did like internal medicine as well, because if I didn't get into psych, there are a lot of avenues. Internal medicine, you do a lot of psych management as well, especially if you're a primary care provider, even inpatient, you can manage a lot of psych medications. Internal medicine also opens up the door for the rest of the specialties, gastroenterology, cardiology, nephrology. So it's basically the door to the body, right? So you can do basically everything else besides surgery in internal medicine. And I even know some internal medicine, even family medicine people who like in very, very rural areas, they even do like endoscopies and colonoscopies. It's kind of crazy, but yeah, internal medicine was basically my backup, but I ended up loving it. Well, I liked it before, which is why it wasn't my backup and why family wasn't. But funnily enough, in my second year of residency, I was offered a psych spot as a second year, but I turned it down because internal medicine it's pretty great. It's kind of like, like you grow up seeing like Batman and these detective shows. You're kind of like the detective. Like you have to figure out what's wrong with the patient, and then you can call in like your backup, like your specialist and stuff. And generally speaking, a good internal medicine doctor, usually you'll know what to do even without specialist support, but and this is kind of the world we live in, you spread the liability by consulting more doctors. Because like, for example, most internal medicine doctors will know how to handle 99% of problems, but we consult because you want to spread the liability, because if you get sued, then you want more people getting sued than just you, otherwise you're kind of screwed. But yeah, internal medicine kind of opens the door. If you want to specialize, you can specialize further with fellowship. If you don't, then you can get out of residency in 3 years, start making money, do clinic, you can do inpatient, you can do only outpatient.
What was the transition like for you going into residency, working those crazy hours?
Yeah, that kind of sucked, especially for me because I grew up in Phoenix. I grew up in a big city. All my friends and family were here. I moved 3 hours north to a town of maybe, I think, 20,000 people, Cottonwood, Arizona. They have like a Walmart and some other stuff, but not much else. So I was all alone there, which didn't help, because first year of residency is probably the toughest year. Your hours, especially when you're on internal medicine wards, and for other specialties when you're on that specialty's wards, because you have rotations in your specialty and you have rotations not in your specialty as well. Bulk of them will be in your specialty. That's basically 13-hour shifts, 6 days a week, with 1 day off. It was tough. It was really hard. Basically, all I did was sleep, eat, go to work, and that's it. And I'm like the type of person who, during med school, I would like stay up all night playing games, and then I would wake up in the morning, go to class, and then be fine. But it was tough. Especially that first year was really, really tough. I got married at the end of my first year, which made things a lot better because I wasn't alone anymore. I had things to do with my wife, but and it eases up as you're going to second and third year. But first year is really tough. You basically, the first day of residency, you get thrown in, and he's like, it doesn't matter if you're from India, it doesn't matter if you're a U.S. grad. You get thrown 8 patients. It doesn't matter if you've never seen a patient before. And here are your 8 patients. Figure it out. And hopefully, you have good seniors who will help walk you through that. But a lot of the time, people don't, which does suck. But I thankfully had very good seniors on my program and very good faculty on my program. So I was lucky in that regard. But it was tough.
Becoming an attending, what was that transition like for you?
It's the best thing ever, honestly. Even as a third year in internal medicine, you still have to do those long shifts when you're on service. You're still on 12 to 13 hours, 6 days a week, 1 day off. Although those rotations become less and less as you go through residency. And once again, it really depends on your training. My training, thankfully, I had a really good training because we were in the middle of nowhere. We didn't have a lot of specialist support, so we got to manage everything. I transitioned from the middle of nowhere to working in a big city at a big hospital that has a lot of specialist support, and honestly, it's been so easy. If you get good training during residency, that's what you want. You want a residency that is tough, because if you're prepared for everything, then you can work anywhere, right? It's so easy for me because I already know what I want to do. I consult the specialist because we want the specialist on board, but because I had good training, it's really easy. And also as an attending, even if no matter where you work, you generally aren't working those long, grueling hours. Generally, I'm a hospitalist, so I'm only inpatient. You are expected to have 12-hour shifts, but most hospitalists work 7 days on, 7 days off. So you basically only working half the year. And most places are what we call round and go, where you'll come in the morning, see your patients, and as soon as you're done seeing your patients, you can leave. Most places you're still responsible for your patients until the end of your shift. So if anything happens, the critical or code or rapid, you have to come back. But otherwise, most people leave. They come in around 8 o'clock, leave around 1, 2. Usually don't have to come back, just answer messages until 7. And then you're done for the night. You're not on call. You don't answer calls all night. You do that for 7 days, and then you're off for 7 days.
That's really nice.
Yeah, some people choose to work 14 days and be off 14 days. Some people choose to work a month and be off a month.
Yeah.
Depends.
Have you had any crazy, memorable patient story?
Actually, this sticks in my mind because this was my first rotation of residency. I was on neurology. And this was something I had never seen before. And our neurologist was fantastic. He was this guy from New Zealand. He was like a wealth of knowledge. We get an admit from the emergency department that they consulted neurology on. There was this elderly gentleman. He was like 60, maybe 65. He came in for transient memory loss. He woke up that morning. He had sex with his wife, and then his wife went to the bathroom, took a shower, and then when she came out, he was just lying on the floor, looking at a chair under the bed, and every 5 seconds he would ask, "Who put that there?" And then he would go to the shower and he would repeat the same question. So for a good 30 minutes to an hour, he couldn't remember more than 5 seconds in the past. So if he asked the question, 10 seconds later he'd ask the same question because he didn't remember what he just asked. And that went on for about 30 minutes to an hour. So they brought him into the emergency department. It was really interesting because it's phenomenal. It's called post-coital transient global amnesia. And what happens is, because during sex, most of your blood is shunted towards the bottom part of your body. It shunts away from the brain. So the vessels in the brain spasm as such. It's kind of they don't record your memory for that short period of time. So even though he saw the chair under the bed and he knew it was there and his wife told him she put it there, 5 seconds later he would forget it because his brain wasn't writing down the data. It was like a hard drive that wasn't working. And I didn't know this was a thing, and it was really cool to see because even when I saw him, he was still undergoing the effects. I'd be like, hey, I'm resident so and so, and then 5 seconds later he'd be like, who are you? That was really interesting, and I think that will always stick with me because it's kind of crazy.
Mm-hmm. Yeah. I want to know your take on the future of medicine, considering stuff like AI and new inventions that come out every day.
So, if you want to talk about the future of medicine, and not just the future of doctors, future of medicine, I think AI is not going to take our jobs. Maybe radiologists, but even then, I don't think so. I think AI, and it's already doing this. It's a tool to make doctors better and more efficient. And I think what you're going to see happen is rather than taking our jobs, our workload will become more because you have tools to help you do the work faster. So I think our corporate overlords, and so now you see maybe 10, 15 patients, so when you start seeing 20, 30, maybe even 40, as you have these AI tools that make you go faster. So even now, for example, like ChatGPT, and there are specialized medical ChatGPT, so to speak, like Open Evidence, which are fantastic. Like before, what you had to do, and even when I was in residency, we had to do this until the last couple of years. If you wanted information about something or you wanted to read up on a topic, you'd go to UpToDate, which is a vast database of different conditions, treatment for conditions, what you look out for, and you'd read the article on UpToDate. Take you maybe 5 to 10 minutes. You learn about the condition, how you treat it, and what you do, and then have all the resources at the bottom, and you would do that. Now what you do, you go to Open Evidence and be like, hey, tell me about transient global amnesia, and it'll think for about 10 seconds, and it'll tell you what it is, how to treat it, what causes it, like very succinctly, and then it'll give you all of the related research and data and articles at the bottom. So I think the future of medicine is more workload with better tools. And unfortunately, I think the future of doctors is going to be less pay and more mid-level encroach, which isn't necessarily a bad thing. MPs and PAs have their places in medicine, but they definitely don't have the same training that doctors do. So as hospitals continue to replace doctors with MPs and PAs, there will probably continue to be more mistakes and more lawsuits. And I think nothing's going to happen until there's like a big lawsuit or a big headline where someone messed up. So, but I think the future of medicine is good because of the advances we're making. But I do think it's going to be less lucrative and or more intensive in the future than it is right now.
If there's one thing that you could change about a general hospital system, what would it be?
Cut out all the mid-level, like not the mid-level, sorry, the admin, the people that are in between you. Like you don't need, like for example, for me, for a doctor, right? You don't need 3 people in between you and like the chief medical officer, right? I think it's all this mid-level. I keep saying mid-level, but mid-levels refer to MPs and PAs. What I mean by mid-level, middle management. Sorry, that's what I mean. There's all this middle management bloat where there's so many administrators, so many people who don't really provide anything of substance, and they're just there to justify their jobs, that increase prices for patients, increase insurance costs, and decrease salaries for everybody else. That's what I would change. All the administrative stuff that goes on in hospitals is probably excuse me, it's probably the worst part of medicine.
And when we look at different social media trends that arise, some good, some bad, has there been anything from your perspective as a physician that just, blares red flags?
So I think, and I know Ozempic has been really big in the past 5 to 10 years, and I think any social media trend where you are taking medication that you don't have a diagnosis to take is dangerous for you. For example, Ozempic, right? People took it for weight loss when they didn't necessarily need weight loss, when they weren't diabetic, when they weren't pre-diabetic. Like Ozempic was made for people who are diabetic or pre-diabetic, and it had an added benefit of losing weight, right? If you were like a normal person, and you weren't overweight, and people started taking Ozempic because they wanted to be skinnier, because they wanted to look better, or whatever. Recent studies are showing that Ozempic usage in people who don't need it, like non-diabetic patients or people who don't actually need a ton of weight loss, has led to like blindness and other long-term side effects. I think any social media trend that, like I said, has you take a medication that you don't have the illness that medication was designed for, is something you should stay away from. And I think even if you want to do it, you should definitely talk to a doctor you trust before taking anything.
Mm-hmm. And does the same thing apply to the different and various doctors on social media supporting or putting out some specific vitamin that's like unheard of, or some supplement, a magic supplement?
So the thing with supplements and vitamins is they're not regulated at all. Drugs are, like Tylenol, antibiotics, antipsychotics, SSRIs. Those are all regulated by the Food and Drug Association. So those have tests, those have studies, those have proven effects, right? Vitamin supplements are not regulated by anybody. Anybody can say anything on any type of pill bottle. Anyone can claim anything, and there's no regulation for it. You don't get in trouble for it. Someone could say this cures cancer, and if it's a vitamin, it doesn't matter because no one regulates that. And if it doesn't cure cancer, it doesn't matter, right? Anyone pushing anything online, it's usually paid for it. And if they're paid for it, then they have an inherent gain from you buying it. And I would generally stay away from anyone online promoting any type of vitamin, any type of supplement. For the most part, I mean, some things, sure, like if someone's promoting like protein powder, and you're in the market for protein powder, sure. But someone, like, I see all these like Golby or Goli vitamins online now that people are like trying to promote. Like, if you're fine and you don't need it, you don't need it, right? I'm not saying vitamins don't have their place. Vitamins are very helpful. If you have something that requires you to take vitamins, right? Most people should take a multivitamin, right? But not everybody needs to take like freaking turmeric root or, so I would stay away from vitamins and supplements for the most part. Most of them don't do anything, especially supplements. Most supplements don't do anything. And if anyone's pushing anything to you, they probably have a hidden agenda that doesn't benefit you and benefits them.
And have you dealt with maybe someone like that?
A lot. Because, like I said, I trained in Cottonwood. It's right next to Sedona, and most of the people who live there are more like, hey, I want to do naturopathic stuff. Hey, I want to take supplements. Hey, I want to take this. Hey, I want to take that, and I don't want to do medications. Actually, you asked me about crazy patients, right? This happened. I had a patient that came in for blood clots, atrial fibrillation. Basically, she needed blood thinners because she would die because she was clotting. She was having strokes. She had a history of a stroke. She had blood clots. She had atrial fibrillation. She had pulmonary embolism. So she was supposed to be on anticoagulation, Eliquis or warfarin. I think she was on Eliquis, which is a full anticoagulation medication. And her son was a Chinese medicine practitioner, okay? I don't know where he got those qualifications from, but so he took his mom off of the medication Eliquis and put her on, I think it was earthworm spit, which supposedly has blood thinning effects. So she was taking that, and lo and behold, she ended up in the hospital with a pulmonary embolism because she clotted because she wasn't taking blood thinners. And that's one example of many. And we had to like argue with this dude to let us put his mom on a blood thinner because she would have died without it. Eventually we got through to him, but that's only one of, I've probably seen over 100 patients that have had similar situations. Yeah, if you're not seeing a MD or a DO, you're not seeing a doctor. And if you're not seeing a doctor, you shouldn't be taking anything that's prescribed to you. Excluding PAs and MPs that work with doctors, I'm talking about like naturopathic people, chiropractic people. These people shouldn't be prescribing medications or supplements or vitamins or anything like that.
And does the same thing apply to people who call themselves anti-vax and don't want their infants or children to be vaccinated?
Listen, if you don't want your children to be vaccinated, I don't think you love your kids. I'm gonna be honest with you. by and large, vaccines have been repeatedly proven to stop what they're supposed to stop. And any study that has any side effect like autism, whatever, first of all, there's no reputable study out there that proves any of that stuff. Yes, some people have negative side effects to vaccines, right? It's true. Some people have negative side effects to some medications. Does that mean everybody should stop taking medications? No. Vaccinations, by and large, are good for society as a whole. Herd immunity is a thing. And I personally wouldn't trust anybody who doesn't vaccinate themselves and their kids.
Going through residency, does that give you the confidence to secure a diagnosis later in the future now as an attending?
For me, yes. Depends on your training. Like I said, if you go to a place where you have a good balance between autonomy and a good balance between attendings who want to teach you and not attendings that are just there so they get paid, you generally will get good training. And residency is actually one of the most important parts of your career where what you put in is what you will get out. The more you study, the more patients you see, the better you'll do. You'll be tired, you won't want to see patients, you'll want to go home and sleep. But let me tell you from experience, throwing yourself into the water with the sharks is the best way to learn. Seeing as many patients as you can will make you better, will make you more confident, and will end up better for you in the long run. Yes, it's 3 to 5 years, depending on your residency of hell. But the better you do during that and the more you work during that, the easier the rest of your life will be. So for me, yes, me and my fellow residents, we had really good training, and that has been echoed outside of our program because we went on audition rotations for fellowship and such. We get really good training, and that translates into a easier life after training. Whereas if you don't get good training, you will not have an easy life after training, because if you put in those long hours, yeah, you'll be tired, you'll have seen like 15-20 patients, you won't want to read anything on up to date. But if you do, and you study and you do well, then when you're an attending, you won't have to, right? Like, thankfully, because I saw as many patients as I did and I did the work I needed to do, I finished my work in half the time of some of my colleagues now as I'm an attending, because the difference in training that you get. So the training you get is really important, and the most important thing is you go to a place that has good training. If you plan on practicing as internal medicine or psych or whatever, if your only goal is to get fellowship, then you should go to a place that has good match rates and has good connections, because you don't plan on practicing as internal medicine, right? But if you do plan on practicing as internal medicine, you should get the best training possible. The status of the residency program shouldn't matter. The ranking of the residency program shouldn't matter. How they match shouldn't matter. If your goal is not to match into fellowship and is to practice as internal medicine, you want the best training as possible. But if your goal is to match into fellowship, then you should be looking at programs that have good match rates for the fellowship that you want. Preferably programs that have that fellowship in that same hospital, and higher tier programs.
Mm-hmm. All in all, I'd like to conclude with asking you, is becoming a doctor and studying medicine worth it in your eyes?
For me, it was worth it. It depends on you as a person. If someone is willing, you basically sacrifice your 20s to become a doctor. And that's how it is. You put off your life for 10 years. Most people don't have kids until after they're done with residency. Most people don't live life until after they're done with residency. You have all this debt. Which at the end of the day, honestly, debt is not that big of a deal. Because unless they get rid of public service loan forgiveness, you make minimum payments for 10 years and they forgive your debt. You're making enough money afterwards that if you continue to live like a resident for a couple of years, you can pay off your debt fairly quickly. For me, it was worth it. I enjoy what I do. It's good money. It's a stable job. You have respect. But if you're someone who isn't willing to put in those 7 to 10 years that you have to, and you just want to get into the workforce, do that. Don't go into medicine for money. There are far better things you can do that will make you far more money than you will in medicine. If you want to go into medicine because it's the best balance, I think, in terms of lifestyle and money and having a good, stable career. For me, it was worth it. And I personally think if you don't have other responsibilities you have to take care of, if you don't have kids, you don't have a family, that you have to provide for, medical school and residency is a very good option if you're able to do it. But everybody is different, and if you have responsibilities in life that you have to take care of, it might not be the best.
That's beautiful. Thank you so much.
Of course.